מה זה? מיכל. Yeah. Okay, so I will present a 5FU cardiotoxicity, and we'll try to answer maybe how can we manage it. I have nothing relevant to disclose. I will start with a clinical case. Mrs. S, she's a 67-year-old female with her past medical history, only past smoker with 10 years pack years, no medication. On 2016, she developed rectal bleeding and tenesmus, and due to that, she performed on July 2016 colonoscopy, and by biopsy, she confirmed the diagnosis of stage 3 adenocarcinoma of colon. She performed the PET-CT, which showed no metastasis. Accordingly, she went hemicolectomy on July 2016, and as accepted, she started with the protocol of FOLFOX, which include continuous 5FU infusion for 44 hours, low coumarin and oxaliplatin, and each treatment should repeat every 2 weeks. During the first cycle of 5FU, she developed on the second day typical chest pain that lasted for 30 minutes and no dyspnea. She went to the ER and performed the ECG, which showed normal sinus with no signs of ischemia. Unfortunately, it was in a different hospital, so I don't have the diagram. And the troponin level was a little bit elevated, 31. So according to that, they stopped the 5FU therapy and admitted her in the pneumit department. A few hours later, and when she was not on any treatment, she developed recurrency of the chest pain. They repeated the ECG, which showed sinus tachycardia, and they described pointed T waves on the anterior and inferior leads, which can be a sign of ischemia. And they repeated the troponin, which was now elevated to 64. Due to that, they decided to do bedside echo by the resident, the cardiologist resident, which described suspected apex hypokinesis and maybe apical ballooning. According to that, she went to coronary angiography, which showed normal coronaries. And they started the treatment with aspirin, ACE inhibitors, beta blockers, and statins. She was in the hospital for a few more days, and 3 days later, they repeated the echo, which showed normal function, and she was released to her home with aspirin, ACE inhibitors, beta blockers, statins, and now they added also the treatment with calcium channel blockers, on the assumption that it was a case of coronary vasospasm. And now she's coming to the cardio-oncology clinic in Ichilov, and now we're facing two important questions. The first one, what is the diagnosis? Is it actually coronary spasm? In favor is, of course, the treatment with 5FU, which is related to coronary spasm, also the normal coronary and the typical chest pain. Can it be Takotsubo? Takotsubo is the broken heart cardiomyopathy, which supported that is the description of the apical ballooning and apex hypokinesis on echo, which can be caused during stress, which is female on oncology therapy, which of course it's stressful. Or is it microvascular disease in a patient, 67-year-old patient that's a past smoker, It is important to decide what is the diagnosis because there's a different treatment for that. For coronary spasm, we will treat with the calcium channel blockers or nitrat. For Takotsubo, the treatment is ACE inhibitors and beta blockers. And for microvascular, we also, of course, we want aspirin and statins. It's not a good decision to give all the medication together because usually all the cancer patients have low blood pressure during the therapy, so we can't give any medication that we want. And so we decided that most probably it is a case of coronary vasospasm. The second question is what we're going to do now with the chemotherapy treatment. Can we challenge the patient or we do need to think about alternative treatment? So when we are talking about cardiac toxicity, so although the field have evolved enormously, there are still many aspects that still have limited data and we don't have all the answers for. 5FU cardiotoxicity is one of them, and when you're reviewing the literature, we see that there's limited data, the data is not updated, the studies are very old, and there are no randomized controlled trials. And this is actually surprising since 5FU cardiotoxicity is pretty pretty common, and actually is the second most common cardiotoxicity after anthracyclines. And another problem is that we don't have any reliable alternative for that treatment. For anthracycline, we have many different treatments for breast cancer, and we don't have many different treatments for GI malignancies. So 5-FU is a synthetic pyrimidine antimetabolite that is used for many cancers, mainly for breast, GI, head and neck, and ovarian. It has two active metabolites that cause DNA damage and RNA damage. And unfortunately, it has a wide range of cardiac toxicity, starting with the most common one, which is angina and myocardial infarction, but also can cause congestive heart failure, sudden cardiac death, and fatal arrhythmias. The mechanism is unfortunately poorly defined. There are limited animal studies and case report, but what we know that it is multifactorial mechanism, including first the coronary vasospasm, which is mostly known, but also mechanism of endothelial damage, autoimmune, myocardial toxicity, accumulation of metabolites, and thrombus formation. And coronary vasospasm is the most commonly known mechanism and suspected. It is confirmed in several studies that shows under ultrasound and angiographic study that there is vasospasm in the brachial and the coronary artery while treated with 5-FU. Also, some studies show that giving vasodilators like nitrates and calcium channel blockers reduced and resolved the chest pain and the ECG changes. Another mechanism is endothelial dysfunction, and several animal studies shows direct endothelial damage by the accumulation of platelet and fibrin and the formation of a thrombus. So how common is 5-FU cardiotoxicity? A review published in 2012 is talking about a range between 1% to up to 18% of cardiotoxicity. It most commonly caused during the first cycle with a median time to symptoms of 12 hours, but can be as late as up to 48 hours. Angina is the most common symptom and can last until 12 hours after the cessation of the drug therapy. Asymptomatic EKG changes is really common, up to 90%, but elevated cardiac enzymes will also only see it about 7%. Another famous review that published in 2009 reviewed the literature almost for 40 years and showed almost 400 cases of 5-FU cardiotoxicity. The majority, about 70%, were during the first cycle, and angina again was the most common symptom, but also myocardial infarction and arrhythmias in about 20% each. Unfortunately, it can cause also acute pulmonary edema, cardiac arrest, and heart failure. ECG changes are really common, about 70%, and cardiac enzyme elevation about 12%. Unfortunately, in almost 50% of the patient, there was a recurrence of the cardiac symptoms during re-challenging to the medications. Most patients started treatment with anti-anginal therapy, nitrates or calcium channel blockers. And unfortunately, there was not insignificant mortality, with 8% mortality due to 5-FU cardiotoxicity and 13% mortality in re-exposure to the medications. So what are the risk factors for cardiotoxicity? Of course, for every other cardiac disease, pre-existing cardiac other disease and heart failure, renal failure, also exposure to chest radiation and other chemotherapy, of course, and also prior symptoms on 5-FU. An important risk factor is the use of longer continuous infusions regimens. And why is it important? First of all, this is a risk factor that we can control and change, unlike the other risk factors. And it is interesting that if you look at anthracyclines, their bolus regimens is a risk factor, and usually we prefer to give continuous. Here it's the opposite, and continuous infusion is a risk factor for cardiotoxicity. And we have several studies showing that information. We have one prospective study showing that among 644 patients, the incidence of cardiotoxicity was 4%. And comparing continuous infusion to short infusion was a higher cardiac toxicity, 7% comparing to 2%. Among most of the patients had acute MI, 30% had ischemia. The review that I showed before also support to this information that short bolus is the incidence of short bolus is less, causes cardiotoxicity with only 1 to 3%, comparing to prolonged regimens and long infusion with 7% and up to 18%. The review by Shaif also confirmed this information, and both reviews shows that also underlying heart disease is, of course, a risk factor for cardiac toxicity. So the question is now, how can we manage those patients? So first of all, we have to treat the acute cardiac event. Of course, it is recommended to stop the 5-FU infusion immediately. To monitor the patient, it is important to say that we need to monitor the patient at least 24 hours and mostly recommended 72 hours after we stop the treatment because a chest pain can reoccur. We, of course, have to rule out coronary disease because in many times there are old patients with risk factors and we can't know if there are any other coronary disease. So we have to decide whether cardiac coronary CT or coronary angiography. If we do find a coronary disease, of course, we need to treat the disease by the guidelines. But in case of suspected coronary vasospasm, the recommended treatment is nitrates or calcium channel blockers or both. So we treated the acute phase, so what we do with the patient now? We still have a patient with ongoing cancer and we need to know how to treat him best. So according to the 2016 ESC position paper published recently, the first act is to withhold chemotherapy in case of myocardial ischemia and only to re-challenge it when there is no absolutely alternative therapies. If we do decide to re-challenge, it's mostly recommended with the treatment of nitrates and or calcium channel blockers. So why shouldn't we re-challenge the patient? Because now most recommendations are not to re-challenge the patients, and this is based on past studies, which are old studies, but in 1999, a study by Becker showed that a very, very high reoccurrence rate of 80% to 100% of cardiac toxicity when we re-challenge the patient. Another review on 2009 shown a death rate of almost 20% when re-challenging the patient. And the other study also show 14% of myocardial infarction and cardiogenic shock and re-challenging. So why should we think about re-challenging the patient? After all, 5-FU is the basic for colon therapy, and there's significant long-term benefits on both reoccurrence and survival, and unfortunately is still superior to other treatments. What are the other treatments? The most common one is Xeloda, which is an oral prodrug of 5-FU, but unfortunately, this treatment also has cardiotoxicity with the incidence over a rate of 5%. Another optional treatment is raltitrexad, which is a thymidylate synthase inhibitor, which luckily doesn't cause cardiac profile, but it's still less beneficial than 5-FU. So what about giving, if we do decide to re-challenge the patient, what about giving prophylaxis vasodilator? Unfortunately, the studies are inconsistent data. Some small publications describe effectiveness, but other publications did not confirm this information. Small studies showed that it did not prevent any cardiotoxicity and showed that on 97 patients, the cardiotoxicity was not prevented and reoccurred in about 12%, which is high. At the moment, there are no prospective randomized trials. I found a few case reports. One of them showed that in patients with no history of cardiac disease and no MI, it is possible to re-challenge the patients with treatment of calcium channel blocker reforms, and they tried it on 2 patients and no recurrence occurred. If the patient had myocardial infarction, as our patient, they decided to discontinue the treatment. An interesting case report published was that with a patient similar to our patient, this 30-year-old patient with stage 3 colorectal adenocarcinoma, which was treated with FOLFOX therapy as our patient. He developed on the first cycle also chest pain with positive troponin, and coronary angiography showed no normal coronary arteries. They decided to re-challenge the patient 2 weeks later, but with a different protocol, which called FLOX chemotherapy. It's actually the same medication as FOLFOX, but instead of continuous infusion, it's a bolus form of infusion. The patient was monitored and was treatment prophylactic with aspirin and calcium channel blockers. He was able to complete his therapy with no recurrence or cardiac events. So the conclusions are that 5-FU myocardial ischemia is common and can be up to 10%, depending on dose, scheduling, and route of administration. It most commonly occur in the first cycle within 2 to 5 days, but can last up to 48 hours. The risk factor are high dose, continuous infusion, concurrent chemotherapy and radiation, of course, cardiac risk factors. There are no consensus about prophylaxis therapy, and the relevant recommendation right now currently is to discontinue the treatment. Unfortunately, there are no reliable chemotherapy alternatives. So the patient came to our clinic. She had a follow-up echo with normal ejection fraction, as was in her release. She's asymptomatic since the last treatment. Her ECG was normal sinus, and the blood tests were normal. So we faced the dilemma. Should we re-challenge? The anti for that is, of course, the very high incidence of occurrence of cardiac and death and even death. But the pro is that we're talking about a young patient with no concomitant diseases, no normal heart function, and no good alternative treatment. And in the end, we still need to remember that, first of all, we need to treat her oncologic disease, that this is the ongoing disease and not the cardiac. So we decided to re-challenge the patient. Of course, I wasn't brave enough doing that only by the literature, so we did advise our colleagues in several medical centers with more experience on the cardio-oncology clinic, and we decided on the following protocol. The patient will start 72 hours before the treatment calcium channel blockers, slow-release nifedipine. She will start also 24 hours before nitrates, and the dosage depends, of course, on her blood pressure. And she will be treated with the FLOX protocol, which is bolus 5-FU and leucovorin and oxaliplatin. This treatment will be every week. Each treatment will be under hospitalization and continuous monitoring, and she will be on close follow-up in the cardio-oncology treatment about every 2 months. During each follow-up in the clinic, she performed an echo. You can see here about the results of 4 echoes. Of course, all echoes with normal ejection fraction, normal diastolic function, and normal right ventricular function. As you can see, we performed a longitudinal strain in each echo, which I can show the images here on 4-chamber view, 2-chamber view, 3-chamber view, and bull's eye. I also have to mention that in our cardio clinic in Ichilov, we do a strain for every patient each time he comes to the clinic, and we follow them. We also followed the biomarkers. Troponin was negative in all times, and we just one time took BNP, which was, of course, normal. And currently, she completed a 6-month chemotherapy. On the cardiac issue, she's asymptomatic with normal cardiac function. And on the oncology, she performed a CT, showed no active disease. Due to the success of that therapy, we had 2 more other patients treated with the same protocol, and up to now, and knock on wood, nothing happened. So to summarize, updated data is needed. Most studies are limited, small, old, and no randomized controlled trials. Re-challenging can be considered. We have to remember all the time that the first disease of this patient is oncologist disease. She has cancer. we need to treat the cancer, and it's a young patient, and we need to give her the best therapy that we can, of course, without causing any other cardiac disease. And of course, the base for that is a close cooperation and trust between the oncologists and the cardiologists with the cardio-oncology clinic. Thank you.
Thank you very much. Question, please. Yes.
There is something I missed from the papers.
You know,
I would give to this patient a high dose statin.